Hi, my name is Brittany Parrish. I am a nurse practitioner student at the University of Memphis, and I am about to do a head-to-toe assessment, and I'm going to scan my room. I'm going to begin by inspecting the patient's skin. The color has a light pink undertone. The temperature is warm. Skin is dry. Texture is soft. There is no bruising, scarring, nevi, no edema. Turgor is elastic, and this is the skin of the head, face, neck, anterior, posterior, chest, and the abdomen. The head is midline in position, normal size, and it's symmetrical. The scalp is there's no lesions, no infestations, there's no depressions or masses. The hair is black, it is soft and thick, and it is of equal distribution. Next, I'm going to move on to palpating the temporal arteries. For tenderness, there's no tenderness. I'm going to palpate the lymph nodes, beginning with the preauricular, postauricular, the tonsillar, submandibular, submental, occipital, anterior cervical, posterior cervical, and the supraclavicular. And they're of normal size, they're movable, and they were non-tender. I'm going to check cranial nerve 5, which is the trigeminal nerve. I'm going to palpate over the masseter muscle while I have the patient clench their jaw. Okay, and that did not have any tenderness or subluxation. I'm also going to have the patient close their eyes, and I'm going to tell them when they feel a touch.
Feel, 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 feel.
I'm also going to palpate TMJ for any subluxation, crepitus, or tenderness. So I have the patient open and close their mouth. Okay, there's no subluxation, crepitus, or tenderness. I'm going to check cranial nerve 7, which is the facial nerve. I'm going to have the patient smile, frown, pucker their lips, puff out their cheeks, and raise their eyebrows. So facial symmetry is intact. Next, I'm going to inspect the ears. They're in normal shape and in normal position. I'm going to palpate the pinnae and the tragus. There's no masses. Are they tender at all?
No.
Okay. I'm going to look inside the ears at the auditory canal and the tympanic membrane. I'm going to raise the ears up and back. And the auditory canal is pink. The tympanic membrane is pearly gray. I don't see any perforations. There is no fluid. Ear up and back. Again, auditory canal is pink. There's no fluid. Tympanic membrane's pearly gray, and there is no perforations. Now I'm going to check cranial nerve 8, which is the auditory nerve. I'm going to have the patient occlude one ear and let me know what I say.
Cat.
Occlude the other ear.
Dog.
Now I'm going to do the Weber test, and it's testing for lateralization. I have the patient let me know when they can no longer hear sound.
I can no longer hear sound.
And I'll do the Renee test, and I'll have the patient tell me when they can no longer feel the vibration and when they can no longer hear sound. This is doing air conduction versus bone conduction.
Can no longer feel. Can no longer hear. No longer feel. No longer hear.
Okay. And air conduction was greater than bone conduction, which is normal. And now I'm going to move on to the eyes. The eyes do not have any discharge. Bilaterally, the lashes curve away from the eyes. The eyebrows go to the ends of the eyes. The palpable fissures are normal bilaterally. I'm going to check the sclera and conjunctiva of the eyes bilaterally. Sclera is white, conjunctiva is pink, upper and lower bilaterally. Next, I'm going to check cranial nerve 2, which is the optic nerve, by using the Snellen chart. And I will have the patient cover one eye, read the lowest line that they can read while I'm standing 6 feet away.
LTFPH. LTFPH.
Okay. So the patient has 20/20 vision in both eyes, and he does not wear corrective lenses. I'm also going to check peripheral central vision by having the patient tell me when they can see my fingers.
I can see them.
Okay, so that is intact, cranial nerve 2. Next, I'm going to check cranial nerve 3, which is the checking for oculomotor, which is checking for pupillary response to light. Okay, so the patient's eyes were equal round and reactive to light. And next I'm going to check accommodation, so I'll have the patient focus on my finger and look at the wall behind me. So the eye is accommodated. And now I'm going to have him focus on my finger and follow it. And his eyes converge, which is normal. Next, I'm going to check cranial nerves 3, oculomotor, 4, trochlear, and 6, abducens for conjugate gaze with extraocular movement by using the 6 fields of gaze. And I'll have the patient follow my finger. So conjugate gaze, the extraocular movement was intact. And now I'm going to look with the ophthalmoscope for the red reflex and other internal eye structures. And the red reflex and the optic discs were present in both eyes bilaterally. I'm going to move on to the nose. The nose is midline and straight, and I'm going to feel for the maxillary sinuses and the frontal sinuses. Are there any tenderness?
No.
Okay. I'm going to check cranial nerve 1, which is the olfactory nerve.
Lavender.
So sense of smell is intact, and the patient's nares were also patent. Looking at the patient's lips, his lips are pink and moist. There's no cracking. If you could open your mouth. Teeth are intact. His tongue is pink. The floor of his mouth is pink. The buccal mucosa is pink. I can see the salivary glands. Can you put your tongue down? Tongue is pink. Tonsils are +1. You can say ah.
Ah.
His uvula and soft palate rose symmetrically upon phonation, which means that cranial nerve 9, the glossopharyngeal, and 10, vagus nerve, are intact. And if you stick out your tongue, move it from side to side. Cranial nerve 12, the hypoglossal nerve, is also intact, and there was no fasciculations noted when he stuck out his tongue, and his tongue is midline. Moving on to the patient's neck. Trachea is midline. I'm going to feel for the patient's thyroid. I'll have him swallow. Okay. I'm going to feel for the patient's carotid arteries. If you could hold your breath. And the other side. Okay. Now I'm going to listen to the carotid arteries with the bell of my stethoscope for any bruits. And there are no bruits. I'm I'm going to have the patient turn around, check the posterior chest. Throughout the video, the patient has not been showing any signs of respiratory distress, not using any accessory muscles, not showing any retractions, not sitting in a tripod position. There's no cyanosis, no nasal flaring, no heaves. The patient's, I'm going to show chest expansion, symmetry. So that was symmetrical. I'm going to do tactile firmitis, so say 99 as you feel my hand.
99, 99, 99, 99.
That was symmetrical. I'm going to percuss down the chest wall. Okay. Now I'm going to listen to the patient's breath sounds, see if there's any adventitious breath sounds. And the patient's breath sounds were clear. I didn't hear any adventitious breath sounds. Also, I did not note any deformities on the patient's backside of his chest. Next, I'm going to do egophony, so I'll have the patient say E as I go down with my stethoscope.
E, 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 E.
Next, I'm going to do bronchophony. I'll have them say 99.
99, 99, 99, 99, 99, 99.
Next, whisper pectoriloquy. I'll have him whisper 99. Okay, so that was normal. There was no signs of consolidation. Now I'll have the patient turn around, do the anterior chest. Again, no deformities noted. Chest is symmetrical. Show symmetrical chest rise. Okay. Symmetrical. Tactile firmitis.
99, 99, 99, 99.
That's symmetrical. I'll listen again as well. Auscultate. Okay. The patient again had clear breath sounds. There's no adventitious sounds. I'm going to move on to the heart. I'm going to listen to all of the patient's heart sounds with the bell and the diaphragm of the stethoscope, beginning with the aortic, which is on the right substernal border, second intercostal space. Pulmonic, left substernal border, second intercostal space. Erb's point, left substernal border, third intercostal space. Tricuspid, left substernal border, fourth intercostal space. And mitral, left substernal border, fifth intercostal space, mid-clavicular line. And now I'm going to find PMI. So I'll find the mid-clavicular line, come down to the fifth intercostal space and palpate. I'm also going to auscultate the apical pulse for 1 minute, and it is 70 beats per minute, which is normal. Now I'm going to have the patient lie down. First thing I'm going to look at is for jugular vein distension. So the patient is up, his head is up 30 to 45 degrees, and I don't see any jugular vein distension, which is normal. I'm also going to look at his chest and look for any heaves or lifts, which I do not see. I'm going to feel on each point to see if there are any thrills. So beginning with the aortic, right substernal border, second intercostal space. Pulmonic, left substernal border, second intercostal space. Herbs point, left substernal border, third intercostal space. Tricuspid, left substernal border, fourth intercostal space. And mitral, left substernal border, fifth intercostal space, midclavicular line. And I did not feel any thrills. And now I'm going to listen to each spot again with the bell and diaphragm of my stethoscope. Aortic, right substernal border, second intercostal space. Pulmonic, left substernal border, second intercostal space. Herbs point, left substernal border, third intercostal space. Tricuspid, left substernal border, fourth intercostal space. And mitral, left substernal border, fifth intercostal space, midclavicular line. And again, just like when the patient was sitting up, his heart sound normal S1, S2. Moving on to the abdomen. The abdomen is symmetrical, has a normal contour, and I'm going to listen to the patient's bowel sounds in all 4 quadrants. And the patient had normal active bowel sounds, and now I'm going to listen to the patient's aorta with the bell of my stethoscope, the renal arteries with the bell of my stethoscope, the iliac arteries with the bell, and the femoral arteries with the bell of my stethoscope. And I was listening for bruits, and I did not hear any bruits at all. Next, I'm going to percuss the quadrants of the abdomen. And there is dullness over organs and tympany over air-filled areas of the abdomen. Finally, I'm going to palpate, beginning with light palpation, and if it's acceptable to the patient, deeper palpation. Is that tender at all?
No.
Okay, so I'll move on to deeper palpation. And on the right side, I can try to palpate for the liver. And if it's enlarged, you can really feel it. I can barely feel it, just a little. Moving on to the left side. The spleen, if it's enlarged, you can feel it. If not, you can't. I didn't feel any masses. I didn't feel the spleen. I could feel the liver just a little. But otherwise, everything felt normal. And now I'm going to check for CVA tenderness. So I'll have the patient sit up. Is that tender at all?
No.
Okay. Moving on to the musculoskeletal assessment, I'm going to palpate and inspect the joints of the fingers, wrists, elbows, shoulders, the hips, the knees, the ankles, and the toes. I didn't feel any crepitus, any swelling, and they didn't seem tender, and there was no redness, so they were all normal. Next, I'm going to do cap refill of the fingers and the toes. They're all less than 3 seconds. Now I'm going to do the pulses, the radial pulses, posterior tibial, and dorsalis pedis. And those were all +2 bilaterally. Next, I'm going to do cerebellar coordination. I'm going to have the patient do serial thumb opposition, so do your fingers like this. Okay, and now do hand flip-flop. Okay, and then finally do finger to finger, so touch your finger to my finger. Okay, and then I'm going to do vibratory sensation, the medial malleolus and the proximal ulnar prominence. So just tell me when you can feel vibration, or if you can feel vibration.
Feel. 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 Feel.
And now I'm going to do graphthesia. So I'm going to close your eyes. Just tell me what I'm drawing on your hand.
An A. An A.
Okay. And then I'm going to do light touch sensation. Let me know, go close your eyes, when I'm touching.
Touch. 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 Touch.
Okay. Now moving on to stereognosis. Close your eyes and then let me know what I'm putting in your hand.
Coin.
Okay.
Key.
Okay. Perfect. Trying to think if I got everything. Now we're going to move on to range of motion. So if I could have you stand, turn to the side, and I'm going to have you bend over. That's good. We're going to do lumbar spine. So I'm going to palpate and inspect the lumbar spine. Is that tender at all?
No.
Normal S curvature, normal alignment. There's no scoliosis, and this is flexion of lumbar spine. If you could just stand, bend back a little bit. That's extension, hyperextension. Okay. And if you could turn, rotation, and now face the camera, go side to side. That's lateral. Okay. Now we're going to do cervical spine. So flexion is forward, extension and hyperextension is all the way back. Okay. Lateral is side to side, and then rotation. Okay. And now for the shoulders, up is flexion, down is extension, hyperextension is back, internal rotation, external rotation, abduction, adduction, and then circumduction. Elbows, flexion, extension, hyperextension. Your wrists, flexion, extension, hyperextension, rotation, radial deviation, ulnar deviation is out. Okay. And your fingers, flexion, extension, hyperextension, abduction, adduction, and then thumb opposition. And now we'll move on to your hips, flexion, okay? And turn to the side. Extension is a little way back. Hyperextension is, yep, turn back to the front. Internal rotation. Lateral. And then out is abduction. Adduction is in. And circumduction. For your knee is flexion, extension, hyperextension. Okay. Now we'll go down to your ankles. Dorsiflexion is up. Plantar flexion is down. Circumduction is around. Inversion is in. Eversion is out. And then for your toes, flexion, extension, hyperextension is up. Abduction, your toes spread apart. Adduction, your toes in together. Now we are going to do the sit on the table and do your So we're going to start with the brachioradialis, your bicep and tricep. Brachioradialis, bicep, and tricep. Patellar, Achilles, and then Babinski. Alright. And now we'll do the strength. So we're going to start with cranial nerve 11, which is the shoulder accessory muscle, strength of the shoulder girdle. So you shrug your shoulders and you don't let me push down. Shrug your shoulders. Okay. And now don't let me push your arms out. Don't let me push your arms in. So those were both 5 out of 5. Flex your arms. Don't let me pull them out. Don't let me push them in. 5 out of 5. And then if you squeeze my fingers, okay, 5 out of 5. And now we're going to do your hips. You push your legs in. Don't let me push them out. And now you push your legs out. Don't let me push them in. That was 5 out of 5. With your knees, I'm going to push in. You push out. Don't let me push them in. And now you don't let me pull your legs out. Okay? And with your feet, don't let me push your feet up. And now don't let me push your feet down. Alright. So all of those were 5 out of 5 bilaterally. And now I'm going to have the patient do his gait. So I'll have him walk towards the camera and then walk back towards me. Okay, normal gait, and then if you could close your eyes and just stand. So he did the Romberg test. The patient had normal balance. He did not sway, did not fall over. And if you could stand on one foot and hop. Okay. And the patient was able to hop on one foot without falling over. And I believe that concludes my assessment for today. Thank you very much.